So if you go to the doctor and your cholesterol is high enough that the doctor feels you should do something about it, don't just brush it off like, no, I'd rather not take anything. Really look into it. If you're not going to just do it right there, look into it and really understand make sure you're making an informed decision. So something like statins, like atorvastatin, like Lipitor and Crestor, all those cholesterol medications, they actually reduce your risk of having a major event by 25%. That's a lot. You know, that's huge. So before you say, I feel fine, I don't need this anymore, maybe make sure that you're making an informed decision so that you're not going to get yourself in trouble down the road. So that being said, though, so if you see the percentages of people that have 80% over the age of 75 have high blood pressure. So the difference, though, between somebody who's maybe 70 and is very independent and functional and somebody who's 85 and maybe needs help with some of their activities. So when we talk about cancer, I kind of went over this already. Who needs screening? Well, like I said, in order to achieve any survival benefit from any of the screenings, you should have at least 5 years of life expectancy. That's why most say by the age of 75, you don't really need to be getting screened as rigidly as you were or as you should prior to that. But I was a little bit, the lifetime cancer risk, and when you're over 65, there's an 11-fold increase incidence of developing cancer versus somebody who's younger. That's why the screenings around that time are so important, because breast cancer, colon cancer, a lot of them are almost preventable, or they can be, if they're caught early enough, they don't have to become a metastatic cancer, or now you're losing a loved, you don't have any, you can only be on a palliative kind of care. So that's why those screenings are important. So with COVID, treating a lot of patients with COVID. I own a hospice as well, and I can't even begin to share how COVID has been it's like living a nightmare sometimes. In some of these group homes where they may have 5 or 10 people living, if somebody gets COVID, because it's been so contagious, it's like you can literally, within hours, see it get to the next room and the next room. And I've had homes where I've literally stayed and spent the night with the patient, taking care of him because he was dying of COVID, and the group home staff all had COVID, and a handful of the patients did not. So they had one person taking care of the patients that didn't have it, and but they didn't have enough people to help the ones that had COVID and that were very quickly literally showing symptoms, and by that night just about unconscious or really struggling to breathe, and within another day or so dying from it. It's literally chilling when you're to see that. But besides that, with COVID, one thing that, if most of you have had it, you've probably experienced some of these symptoms. I know I have, but the chronic symptoms, the things that kind of linger after COVID. So because it's such a massive inflammatory process in your body, it just does this systemic sort of inflammation. So if you think about it, every organ is affected when you have COVID, and that's why you see people that are barely middle-aged having a stroke or a heart attack. Recently had will often get that inflammatory response. Another thing I see a lot of is the psychiatric issues after COVID, and I don't mean necessarily immediately after, but months after. I mean, I have some people that never had anxiety or depression in their life, and now they have panic attacks, and they don't know why, but it's happened ever since. The only difference is they had COVID, and maybe somebody they knew well died of COVID, and they just, they can't get out of that. They suffer greatly from that. Depression, I think I read like 2/3 of people will have some episode of depression after COVID, usually 6 to 9 months after COVID. That's pretty profound. And the interesting thing is, because it's due primarily to the inflammation in the brain, a lot of times the antidepressants that we would typically use, or the typical treatments, people don't respond very well to them. They're not as effective because it's not your typical depression, so to speak. Also, cognitive problems. I can joke about it, but I'm serious at the same time. I know that I have cognitive slowing after COVID. Like, I get it for people that can't get their words out or have thought blocking. So and it is a fairly common problem for people that they're slower to be able to process and think, and maybe just getting a sentence out, it's like so much extra effort sometimes. So it can definitely do some real damage. So now that we went over the top leading causes of death, that's a depressing topic. Dementia and Alzheimer's, this isn't number 4, but I feel like at least in my line of work, the people that I see, this is absolutely the biggest, the most difficult thing for a patient and the family to deal with. And this is the main reason why people end up in a group home or some other sort of living environment, because eventually their loved ones can't take care of them in the state. So dementia or Alzheimer's is it is the 7th leading cause of death. So it does eventually kill you. A lot of people don't realize that. They think you're going to get dementia, the loved one has dementia, they're going to be like that, and they're just going to be like that, and something else will eventually, lead to their demise. But dementia does progress to the point where when you have severe advanced dementia, you can't hold your head up, you can't swallow, you're not even hungry. Everything is extremely debilitated. So dementia does progress. Now, it depends on the type of dementia. The most common is Alzheimer's, that's why I put it up here. And so I'll focus mostly on that. But dementia does continue to get worse and worse. So the interesting thing is, we often see changes in the brain up to a decade before anybody even has symptoms. I think that's pretty impressive. The other thing is, most people will have symptoms for probably 5 to 7 years before they're even diagnosed, usually about 5 years. I remember a couple of years ago, my mom did this. She started buying t-shirts and was like hoarding them in the closet, and she's always been such a clean freak. Or I noticed when I was there last time, there's all this expired food in the fridge, and she's never been that way. Or maybe it's a personality change that's something's a little bit off, but they can't quite put their finger on it. So these things are really hard to identify when they're happening, because so many different things can explain them. But most often, these symptoms have been going on for quite some time before they become apparent enough that somebody is getting diagnosed. Another interesting thing is early stages of dementia will often look like depression. So it could be depression or it could be dementia. So when somebody seems maybe more withdrawn, They're just not as talkative. Maybe they just don't show as much expression as they usually would. They don't joke around as much. They're just changed a little bit. That could be the beginning of dementia, or it may be wise to have that loved one evaluated to see if they have depression, because if you have depression, it will make dementia worse faster. So if you treat your depression, then your memory issues that progression will slow down. Another interesting fact that is fairly new, from what I understand, is a newer finding is that smokers have a 30 to 40% increased risk of dementia. I didn't know that. There's all kinds of other health risk factors like diabetes, high blood pressure, and anything that affects the blood flow to the brain can cause a vascular dementia. So this is where smoking, of course, compromises the blood flow to the brain and puts you in the same risk category as somebody who has high blood pressure and diabetes. So as I mentioned, the mild stages of dementia, these people with mild dementia typically can function okay, except for maybe some of the more complex tasks, like they're probably not going to be cooking independently anymore. And it often happens where this is realized after somebody leaves the burner on, or they burn something because they forgot they had the burner on or they had the stove on. So safety can become an issue. They tend to socialize less because their brain is processing things slower, and maybe they don't have the complex thinking anymore about something in society, about the news or whatever. They probably don't know that information, so they can't often engage in conversations that you might be having, or maybe they can't keep up when you're having a group conversation. It's too fast and they can't process that. And sometimes just having that, if they'll have that awareness that they aren't remembering things and it's very bothersome to them. And so to play it safe, they kind of don't engage because they don't often want to get caught. They don't want anybody to notice that they're struggling with anything like that. So with moderate dementia, this is more the stage that people start to help loved ones, because it can be very difficult to manage and to know how to handle certain people. And not everybody with dementia has changes in behavior and all of that. Some people don't have any of those changes, but when they do, you know it, and it's very difficult for the whole family. So at a moderate stage, people will often need help with maybe when they get up in the morning to get dressed, they put on their clothes over their pajamas, or they don't quite know how to do the buttons or the zippers anymore, or they have several shirts on. So they maybe can do it, but fall when they have like a mild to moderate dementia, because they're just not, their judgment isn't as good. Or they get up quickly and the blood flow, isn't in the head, and then they're on the floor. So they're a high fall risk. So safety in the home is really important. Wandering is a big thing. I would say probably the biggest reason that people finally in families get a care aide or somebody in the home, or they have their loved one in another higher level of care, is because of this sleep problem. So it's not unusual for people to sundown with dementia, and so in the afternoon or evening, they get progressively more confused, or maybe they get agitated and they're like a total different person. I literally have this 99-year-old little lady that still walks, and she's fast, and she uses a walker, and she is the sweetest little thing all day until about 3 o'clock in the witching hour. the group home says, where she will stand there with her walker and just watch people like a hawk and just, taunt them with her walker. And she'll pick up her walker, and she's hit other residents with her walker. This woman is probably 80 pounds. She's almost 100 years old. And she literally goes into this, she doesn't even know what she's doing. You can't redirect her. She's bitten some of our care aides that we have, like if she's in this mental state. So she goes into like a state of psychosis, and every day, I got her meds right now, so she's better, but it's interesting because that's not unusual. We'll have a period of time during the day that it's kind of like a colicky baby, that no matter what you do, they're going to present that way. And sometimes you can get it a little bit better with medications, and sometimes you just have to control their environment, like take away all the little knickknacks and things that can be used as weapons during that time, and make sure that they're safe. So every individual with dementia presents differently, no two are alike, and they all respond differently to medications, and there's virtually almost no medications approved to be used to help when they're having some of this agitation and behavior, so it's a very difficult thing to manage. So when somebody gets to advanced dementia, this is often when we start, when we see them in our hospice. I would say probably the majority of our patients are in our hospice have a dementia diagnosis. So when somebody gets to that phase where they probably have 6 months or so to live, or a year, they usually can't say more than 5 to 6 words. They need help pretty much with all of their activities of daily living. They may be sleeping 18 hours of the day. They oftentimes, as dementia progresses, people's swallowing gets affected. So if somebody, if a loved one has dementia and they're now coughing when they're drinking their coffee or water, that is a red flag, because they're probably aspirating, they're probably getting some in their lungs, or they may not know how to use their utensils anymore. They don't know, they're trying to eat their napkin, they don't know what to do with it. Or so they just look at their food because they don't understand, they don't know what the utensil is for. So it comes to a point where you have to make all these changes to adapt and accommodate when somebody gets to that phase, so that you can get them to eat. Maybe you're pureeing their food. Oftentimes, we give them ice cream and chocolate and put some protein powder in there, because sweets are, people with dementia love chocolate and they love sweets. So, advanced care planning, this is probably something that most of you have not, maybe you have, maybe I'm surprised. Most people do not do until it becomes crunch time, or they're in a crisis mode and now they have to do it. So the thing with advanced care planning is the main goal is so that you, as an individual, can make choices about the care that you get in the event you can't speak for yourself or something happens. So when somebody goes to the hospital when they've had a stroke or they've been in a car accident and they don't have any sort of advanced care planning, any advanced directive, or they haven't told a single loved one about what they would want done, unfortunately, like I said, in our medical community, they will do everything until it becomes basically unethical. So they will do everything to keep you alive until they know they can't, basically, because that's what we're trained to do. So if you don't specify what you would want that to look like, if something happened to you, then you're leaving it up to somebody else to make that decision. And that's why it's so, so important that you think about these things and you have some idea of what would you want? What does that look like to you? Some people want to be kept alive no matter what. Okay, what are you willing to sacrifice, or what are you willing to go through for that to happen? Are you okay with being kept alive no matter what if we can't control your pain? If you're having trouble breathing, if you have a tube in your belly to feed you, and a ventilator, and all of these things, if that's what you want, that's absolutely fine, but you just specify that. But some people on the other end of the spectrum might say, if I don't recognize my spouse and kids, and I can't wipe my own butt, don't you dare send me to the hospital ever again. Or, you make me comfortable, but don't you dare put me through surgery or do anything aggressive or invasive to keep me living any longer than what is naturally intended for me. So there's both ends of the spectrum. So for the most part, advanced directive consists of a living will and a medical power of attorney, or there's all kinds of different names for that, a surrogate. So if you do nothing else, at the very least, have somebody appointed that you will have make decisions for you. And if it's your spouse, you still need to have a conversation with them, because when they look at studies and see, would your spouse do what you would want them to do? Most of the time, it's completely different than what you would choose to have done for yourself. So you have to communicate your wishes. You don't even have to have them written down, but at least talk about what does that look like for you? What do you value? What's important to you? What is quality of life for you? At what point do you want nature to take its course if quality of life is no longer considered quality of life to you? Because to everybody it can be different. And these things that you talk about, and even if you fill out an advanced directive, nothing is set in stone that if you go to the hospital and you have this, and you're like, I want everything done, but in your advanced directive it says, don't do anything, they're not gonna be like, oh, nope, it says right here. So you can change that this evening. You can change it at the drop of a hat. You can change it any time you want. It's not necessarily legally binding. It's a legal document, but it is not, the only thing that can be done. So it shouldn't be something that you're afraid to this, or something happened to you. Maybe you have a stroke down the road, and maybe now you don't want everything done because you're completely debilitated. And if you were to go into cardiac arrest, maybe you don't want to be resuscitated and now have a feeding tube and everything else. Whereas maybe in the past you had a better chance of having a good outcome with that. So you can change. This is always evolving. So, but at least starting the conversation and start thinking about what would you want in the event something happened, because we never plan to get in a bad car accident or to have a heart attack or a stroke. We don't plan those things. So you can't wait until it's time to decide that, because you won't be around to do that. Another important thing is if you have adult children or siblings that don't have a spouse or don't have children, what are their wishes? What's the plan for them? Have they thought about it? Do they, most people haven't even thought about it. They just, whatever happens, happens kind of thing. But then you're stuck in the situation to say you have a sibling that doesn't have any family, and now they end up ill and they can't make decisions on their own. Now it falls on you. And so now you're trying to figure out, well, what would he want? I don't know, what would he want? So, and this happens all of the time. It's like oftentimes like a niece or a nephew that lives in another state that ends up becoming the medical power of attorney, and they don't even know a lick about the patient a lot of times, but they'll go start with a spouse and then a kid, and they'll just keep going down the chain until they find somebody that will say, yes, I'll make decisions for them. Otherwise, it's left in the hands of the medical community. So, like I said, the medical power of attorney, again, this is somebody that you appoint. It doesn't have to be necessarily on a notarized form. It can be, but it doesn't have to be. You can simply, if you talk about, if you have 10 kids, think of several kids that you could maybe have that discussion with, and maybe they're the kids that either they have a little bit of medical knowledge, or they're not going to get, they're going to be less likely to get so emotionally distraught if they have to make these decisions, that if they have to follow through with your choices or decisions that you've made. But I can tell you there's nothing more tragic and difficult than family members having to make these decisions, kids having to make these decisions for their mom or their dad, because nobody wants to be responsible for potentially ending somebody's life or interrupting the chance of somebody getting better. And so you see families that don't speak anymore to each other because it was such a battle, when their mom was on the ventilator and there's no chance at surviving. And you have one person that says, well, she wouldn't want this, if there's no chance, but then maybe the other three think you're crazy. So when you think about it outside of a crisis, it seems like common sense. Well, of course I wouldn't keep them on the ventilator, but when you're living that, when you're in that situation, emotionally, it's a lot more difficult to make a sound, a rational decision like that. So you have to give them the information so they don't have to make those tough choices for you. So again, a living will is basically what would you want done or what would you not want? Things to ask yourself, what brings you joy? If you find joy in being able to engage in conversation with your loved ones, and you are in a communicate, then would that be a problem for you? Would you want to continue living that way? So there's a lot of websites out there. One of them, this is Prepare for Your Care, is one of them. I went on there. It has some really good information about advanced directives and living wills, and just helps you to kind of start that thought process, because if you say, well, what would you want? Well, I don't know what I would want. But then if you start thinking about questions like, well, what's important to you? What do you value? What is quality of life to you? What are you willing to sacrifice to keep whatever that is? So once you start answering questions like that, it becomes very apparent, I think, for most people what that would look like for them. So part of an advanced directive also is something called the DNR. I'm sure most of you are familiar with that. It's an orange form, and it has to be on an orange form for it to be legally valid, I guess. So a DNR basically means do not resuscitate. So if you have a DNR form, you should have it on your refrigerator, inside your cabinet, somewhere visible, because if somebody were to call 911 and you did not want to be resuscitated, unless they see that form, they have to resuscitate you. If you're in the store and you drop and somebody calls 911, if you don't have that form on you in even a wallet size or whatever, even if your spouse is there and says, no, they don't want, no, they don't want CPR, legally they have to perform CPR. So this is the only way to protect you from having those interventions done. The interesting thing is 81% of people think that, or over the age of 70, think they have a 50% chance of survival, which that seems like that would make sense. But think of CPR as, this isn't, like if you're thinking of an advanced directive, this isn't just, oh, I want to be a DNR or I want to be a full code, meaning I want them to intubate me, I want them to do chest compressions. CPR is something that happens after you're dead. So when your heart stops or you quit breathing, that's when CPR kicks in. Have a feeding tube, getting surgeries. You could have all of those interventions that you don't want, thinking that you're not going to have that because you filled out a DNR. The DNR does not protect you from any of that stuff. Those are all things that happen when you're still alive and trying to survive, whereas a DNR kicks in after you're physiologically dead. So, all right, let's see. So when we look at CPR and how effective it is, it's very grim. Most people think, and it's because in movies and everything, they make CPR look like, oh, you just go pound on their chest and then they get up and they walk home. That doesn't happen ever. And that's the difficult thing is most people have absolutely no idea. So they have no idea that their chance of surviving is almost null. And if you do survive, that it's typically a very, there's no quality of life there. So when CPR happens outside of the hospital setting, 6% of people will survive. In the hospital, it's 8%. For CPR to be effective, you almost always have to break ribs, especially in elderly people. Kids, not so much. In elderly people, I guarantee you, if you don't have broken ribs, then your CPR, they weren't doing it effectively. So it's a very traumatic process that you have to think of it like, this is, do I want this to happen after I die? Do I want someone to try to bring me back to life? Because that's what a DNR means, or CPR means at that point. Most of the time, people have neurological complications. They can have bleeding in the chest. It's a very poor outcome. It's kind of like when you think of when they say that there was a near drowning. A lot of people think a near drowning, oh good, well they didn't drown. Well, a near drowning typically means that maybe the kid, they didn't die because maybe they got CPR, but they have no neurological, they have no quality of life. They may be on a ventilator for the rest of their life. They may be a vegetable. That's a near drowning. So it's a very similar concept that it's not, oh good, they saved, they're good, you know, they're swimming in the water the next day. So when we look at this a little bit more depth, for anybody with no medical conditions, and this is from 0 to adulthood, your chance of surviving in the hospital, surviving CPR is 27%. So that goes for every kid, everybody else that has absolutely no medical issues at all. And that's in the hospital where there's a code cart, at least one code cart at the end of every hall. So you have the best chance of anything. Once you hit 65 and you have any medical condition at all, look at how much that drops. Now you have a 9% chance of survival. And that doesn't mean you have to have congestive heart failure or something like that. It could be maybe you're diabetic, it could be maybe you just have a thyroid problem. Any medical condition at all, your chance of surviving 65 and up in the hospital is 9%. And as you can see, it just gets more and more depressing. But the reason why I think it's so important that you know this is because when you have people that are in their 80s and they're pretty debilitated or have dementia, if you're their loved one, remember this, because when you're sending them to the hospital for pneumonia or for something, and they can't have anybody with them, and they have no idea what's going on, you are absolutely causing them, I don't want to say absolutely, but 99% of the time, you are causing them more harm than good. So when you have a loved one that's frail, that has medical issues, and you want everything done, just remember that your chance is almost null of surviving that. And it's a very tragic process at that. So a lot of times you won't get that information from the provider won't have that discussion with you, which is a shame, but those are really important for you to remember, so you're not putting your loved one, you're not having some false hope for them when, it's not really something that they can survive.